Welcome to Final BDS Made Easy. Discuss various rich augmentation techniques for prosthetic rehabilitation as one of the 7 marker questions from the subject of oral and maxillofacial surgery for your final year BDS exams. This answer is prepared from Nilma Malik. So if you want to refer, you can refer to this textbook. Following are the various techniques which are used for ridge augmentation. For mandible, these are the superior border augmentation, inferior border augmentation, interpositional or sandwich bone grafts, visor osteotomy, vertical osteotomy, onlay grafting, pedicled augmentation, horizontal osteotomy, which is one of the recent advances, and ridge split technique for implant placement. For maxilla, these are only bone grafting, only grafting of alloplastic material, interpositional or sandwich grafts, which include the sinus lift procedure, and ridge split technique for implant placement. Then augmentation in combination with orthodontic surgery includes the mandibular osteotomy procedure, maxillary osteotomy procedure, combination procedure, and the last one is the distraction osteogenesis. Let's take a look at each one. So the first one is the superior border grafting. It is used when the alveolar ridge height is less than 10 millimeters. In this procedure, autogenous rib grafts are taken typically from the 5th to 9th ribs. They are contoured and fixed to the superior border of the mandible. The rib graft is molded and secured using transosseous or circummandibular wiring, and iliac crest grafting is also another option. Advantage of this technique is that it is effective in increasing the ridge height. However, the disadvantage is that it requires a second surgical site, potential for donor site morbidity, and continued resorption of the grafted site. I suggest you look at the diagrams from the textbook directly. Second one is the inferior border grafting. It is applied when the alveolar ridge height is less than 5 to 8 millimeters and at risk of pathological fracture. In this procedure, a hollowed freeze-dried allogenic cadaver mandible is filled with autogenous cancellous bone graft particles from the iliac crest. The graft is then fixed to the inferior border of the mandible using sutures, and the neck flap is closed. It allows for the placement of osseointegrated implants after surgery. Significant bone augmentation can be achieved and better aesthetic outcomes can be achieved. Disadvantages includes that it involves extraoral surgery leading to a longer recovery time. Third one is the interpositional bone grafts, also called the sandwich grafting. It is used primarily for the anterior mandible between the mental foramina. A horizontal osteotomy is performed to split the residual alveolar bone, creating a gap where the bone graft, which can be autogenous, allogenic, or hydroxyapatite, it is placed. Implants can be placed through the superior segment of the bone. Advantages of using this technique is lower resorption rate compared to onlay grafting, more predictable long-term outcomes, and decreased nerve paresthesia risk. Disadvantages include that it requires a longer time before the prosthesis can be delivered. Fourth one is the onlay grafting. It is used when adequate ridge height is present but the width is insufficient. In this procedure, hydroxyapatite or autogenous bone or other graft materials are placed on the external cortex of the alveolar ridge. A barrier membrane is often used to support regeneration and preservation of the graft. Advantages includes that it improves both the height and width of the alveolar bone, and it can be used in anterior and posterior regions and allows for implant placement. Disadvantage includes that it requires extensive surgical skill and it has a longer healing time. One is the visor osteotomy, also called the vertical osteotomy. It is designed to increase the height of the mandibular ridge. In this procedure, the mandible is split in a buccolingual direction and the lingual section is repositioned superiorly. Cancerous bone graft material is then placed between the superior and inferior segments. It allows for substantial height increase, stable repositioning of segments, and correction of mild to moderate anteroposterior discrepancies. Risks include nerve paresthesia, dysesthesia, and the inability to wear dentures for several months after surgery. Sixth one is the sinus lift procedure, also called sinus grafting. It is primarily used to aid in the placement of implants in the posterior maxilla where the sinus floor is close to the alveolar ridge. The sinus lining is lifted and a bone graft is placed between the sinus lining and the alveolar crest. It facilitates implant placement in cases with inadequate bone in the posterior maxilla. Potential complications include sinus membrane perforation and infection. That's it. Thank you for watching. If you appreciate this video, do hit the like button, share it with your friends, and please subscribe to my YouTube channel. Stay tuned for more such videos.